excited what we've accomplished so far. So I appreciate everybody in this room because I know a lot of you have loved ones who were affected in one way or another with this terrible disease. So with that said, I want to introduce my husband, Richard Serrato. He'll be our MC for this evening.
Once again, thank you everyone for coming out tonight and celebrating the Lenny Breath event. Amazing Breath is we have a mission to help educate those afflicted with lung cancer. A lot of folks out there don't have a support group or have means of getting information about this disease. So we want to be able to reach out to the community and say, here's a resource that will help you and possibly be a shoulder to lean on in regards to your cancer, and also be able to help the caregivers that are by your side as well, to give you that support system. Now, we have an online support group that we started up, so that this way, if anyone has a family member or a friend afflicted by the disease, you can contact us online, and then we can offer whatever support we can. If it's just a shoulder to lean on, we want to be able to do that. Okay? Now, we have a full evening, a lot of stuff going on. First of all, I would like to introduce Dr. Snyder from Presbyterian Hospital. He's going to be our first speaker. And then we'll go from there and see how more fun going on. Thank you, Dr.
Can everybody hear me? Yes. Okay. Well, thank you very much. I really appreciate the opportunity to come speak again. This is the second year that I've been able to do this. And I really want to applaud Yolanda and your family's efforts for this. I don't have to stress to everybody, lung cancer is a huge problem. And oftentimes I don't think our country fully realizes how serious this disease is. I don't like talking about statistics, but I'll take a step back and say that for 10 years I've really focused on the treatment of lung cancer since I finished my fellowship. I am on faculty at Weill Cornell New York Presbyterian, where I do research for lung cancer and treat patients with this disease. And so I am very aware that this is a problem that we need to spread the message. It is, and again, I don't like to touch on statistics, but we really have to stress the gravity of this disease. This is the #1 cancer killer in the United States. Okay, if you would poll a lot of people and say, what do you think the #1 cancer killer is in women, they'd say, oh, breast cancer. It's not. Okay, it is lung cancer. And lung cancer kills more people in our country than breast cancer, prostate cancer, colorectal cancer, and pancreatic cancer combined. Those are the next top 4. And because of the stigma associated with it, because there is this unfair, well, they deserved it, it doesn't get a lot of attention. And again, I am jealous, but I'm also envious of my breast cancer colleagues and supporters. They have a very well-organized system. There's a pink ribbon on everything that you turn around. You've got football players wearing pink shoes, and it's to a certain degree sexy to support breast cancer research. And because of that, for every $1 that is spent on lung cancer research, $9 is spent on breast cancer research. And for that reason, breast cancer research is 10 years ahead of lung cancer and pretty much all the other malignancies. We really need to duplicate their efforts because, boy, they got it right. And we've really seen some major advances in breast cancer, and we need to translate that into lung cancer. Now, I'm going to touch on a few things, talk briefly about lung cancer, about kind of what's new and coming down the pike. I'd also like to leave this a little bit informal for the people that have any specific questions about lung cancer. I'd be happy to answer them. and make sure that we can kind of cover the ground here in the next about 10-15 minutes. Now, when you think about lung cancer or any cancer in general, I always start off by saying that is that person. Okay, this isn't a virus, this isn't a bacteria. These are lung cells, okay, but the machinery is broken in these cells. The cells have figured out how to grow uncontrollably. And they've learned to travel to other areas of the body that they're not supposed to be in. And that's what makes cancer bad, is that it goes places it shouldn't. So, when somebody has lung cancer that has gone to the liver, that's not liver cancer. Those are lung cells that have somehow figured out how to slip into the bloodstream and go set up shop someplace else in the body. And unfortunately, in lung cancer, 75% of patients at the time they are diagnosed will have advanced stage disease. So this is a hard cancer to catch early. Oftentimes my patients ask, well, how long do you think I've had this? And oftentimes I'll say months. And they're shocked, months. If it had been there for years, we'd be able to catch it sooner. We'd have better screening mechanisms. But the fact of the matter is, more often than not, by the time symptoms develop, by the time somebody has a cough or pain or shortness of breath or some symptom that gets them to a doctor, 75% of the time it is at stage 3 and stage 4. And stage 3 is really hard to get rid of, and unfortunately we don't still know how to get rid of stage 4 disease. And so oftentimes at least giving some assurance that I know that maybe you felt a little twinge of pain 6 months ago, but chances are it was already metastasized at that time. So it really is tough to catch early. Oftentimes it's just on accident. The early stage cancers that we find are oftentimes because the patients went to the doctor for a different problem, or they were in the emergency room because they were in a car accident, or got a chest x-ray that showed a spot. And so we have made some strides in being able to detect it earlier with CT screening, and we touched upon this for those of you that were here last year. But the screening, again, is very complicated. Scans just tell you something is there. It doesn't really tell you what it is. So I try to describe that our scans will, especially in our high-risk patient population, which we mean somebody who has had at least a 30-pack-year smoking history, chances are better than not we're going to find some spot. But about 97% of them are benign. Boy, it sure makes people worry that you found a spot and we need to follow it with other tests. It might be too small to stick a needle in it. And so it's not as simple as getting just a scan and letting you know do you have it or not. But for people that may be at high risk, meaning that either what we've defined is that somebody who has had a significant smoking history, clearly at higher risk than people who haven't, it's a good thing to talk with your primary care doctor and maybe see a pulmonologist about that. Once again, though, the main problem that we are dealing with is what to do with our advanced stage patients. We are working desperately to find better treatments, and there have been some breakthroughs over the last year, and a couple that I want to touch on. One is this concept of precision medicine. And the other one is immunotherapy. Okay, now we have this buzz phrase of precision medicine, meaning that we are tailoring the treatment based on an individual's cancer. Everybody's cancer is different, and trying to unlock the specifics of that cancer and then using the most appropriate therapy is the way things are done.